clinic, why could you choose a model-based approach for brachytherapy? What type of treatments would be most affected by these? What CT considerations need to be made? How would you commission this program? Are there any uncertainties? And how does this affect dose prescriptions? So, like usual, every time we have a chance to discuss a task group or mention a reference, we are going to do that. And that is going to be TG 186. There we go. So you might want to consider a model-based approach for brachytherapy because TG43 is limited. It does not use a heterogeneity correction. It assumes everything is water, which we know isn't correct, but that's what we've done for years. That's what brachytherapy has always been based off of. So we know it works through clinical trials. But if we want an accurate depiction of the dose distribution that is actually being given, we need to account for that. Also, within TG43, that does not account for the interseed attenuation. It also doesn't account for the patient dimensional boundaries. So all those things wrap into potential reasons why you would want to consider a model-based approach that uses a heterogeneity correction. So what type of treatments what ones are going to be most affected? So anything that is going to use a lower energy seed or activity. So we are going to have a higher discrepancy of these. So I'm going to write this down here. So if we have a lower energy, then we're going to talk about maybe 10 to 20% off compared to TG43. And then if it's a middle energy, higher energy type things, I'm going to say about 5 to 10% you're going to be off. Still something that is pretty significant when you actually think about it. And if you want to put these into real life examples, so palladium 103, iodine 125, anything with Zoft, the COMS, the iPlax, those are all going to have big errors. So again, that's compared to TG43, not saying that what we're doing now isn't working or isn't safe, because it is, but if you're just simply comparing absolute dose from model-based approach to TG43, those are the percentages you can expect to be off. So what CT considerations need to be made? So the CTs now first need to be segmented, and they need to be segmented into tissue types because that matters with these low energy x-rays that we are using. That's the very first step you must do. Also, you need to care more about artifacts. Typically in brachytherapy right now, you care about artifacts because maybe you can't see exactly where the catheter is. But in terms of dose, it assumes it's water, so who cares? But the artifacts, if you were going to account for heterogeneities, that's going to make a big deal. And then finally, you also want to assign, typically you do this by hand, so you're going to hand assign HU values to relevant tissues. And that certainly is an extra step, but something that you must do, again, because you have to have a heterogeneity correction, which is going to take the CT number or HU and relate that to an electron density. So now how would we commission this program? So first of all, you want to compare with TG43. And ideally, what you want to do is compare it in water, because at that point, this should be very similar. Now, if you're comparing in water, you can expect to get up to 2% deviation. It doesn't need to be perfect, but it needs to be very close because it's just water. They both should be equal. And if they aren't, you have a problem on your hands. You then can do a gamma analysis on brachytherapy, and that do 2% 2 millimeter. Again, look at TG 186. This covers all of this as well. You want that to pass that gamma analysis greater than 99%. Then you want to use Monte Carlo to find dose on a phantom and see how that model specifically does. And then to talk about the uncertainties in this, first of all, you have a trade off in time versus accuracy. So, obviously, potentially, I should say, the more accurate, the longer it's going to take, similar to Monte Carlo. And sometimes you don't have hours to wait for a dose calculation to actually calculate. So, you have a trade off. There also, you may not be able to have a voxel size smaller than 2 millimeters cubed. And then there's limitations at which applicators you can use potentially as well with model based approach. So, all things you want to consider. And now, how does this affect dose prescriptions? So, remember, we have been treating with TG43. We know that the dose distribution we're seeing on the computer isn't exactly what's being given. So, that poses a question, well, should we change the dose prescription now, the dose schemes that we're all used to? Because now we're actually seeing what dose we are being given. So, for example, a model based approach actually gives and shows 5% less dose than TG43 and a mammocyte treatment, meaning you're tempted to now give 105% of the normal scheme because you know, okay, now my tumor is actually getting 30 gray. However, the recommendation is to use TG43 until further research is done. So, understand why this dose prescription may in time change, but for right now, the recommendation is to use TG43 until further research is done. If you have any questions about this, it's very fascinating. Please comment, ask below. I'll happily help where I can. Best of luck studying and good luck on your exam.